Hernandez, and I'm back with Nclex.Solved, and today I'm going to be talking about the peri-operative patient. So any patient that has undergone surgery primarily focuses on two main segments of the peri-operative phase, the pre-op and the post-op, because the role of a VN during surgery is rather limited. So let's discuss some of these concepts real quick. So when we say peri-operative, we're talking about any patient that has undergone surgery, whether it's before, during, or after surgery. That's what peri-operative means. And let's focus on the pre-op. Pre-op is essentially teachings. You have to understand basic concepts that come along with the pre-op patient. For instance, if the patient is going to have surgery, what medication should you be aware of that should have been discontinued before the surgical procedure? Any medications that deal with the clotting cascade, such as anticoagulants, aspirin, warfarin, heparin, clopidogrel, any medication, Plavix, any medication that the patient may be taking before the actual procedure, there has to be education about discontinuing the drug or checking with the physician to make sure it's safe to take those drugs, because what are we going to be doing during surgery? Cutting the patient up. And if the patient's taking those drugs, well, it's going to potentiate bleeding. So you want to look at labs. You want to look at your PT-INR for Coumadin. You want to look at your PTT for heparin. You want to look at your platelet count. You want to look at your CBC. Is the patient's hemoglobin in normal values? Is the patient diabetic? If the patient's diabetic, you have to understand that the patient is going to be NPO before surgery. If that's the case, well, what type of fluids are they on? Does it contain dextrose, D5 half NS? Or D5 NS, excuse me. These are all things that you're supposed to be thinking about when dealing with the pre-op patient. It doesn't matter what system we're talking about. It just means that you're looking at the whole picture and that you understand the concept. So your pre-op teaching is very important, okay? Of course, we have to make sure that we get informed consent. Our role as a nurse is just to obtain signature, and if the patient still has any questions, we have to refer them back to the surgeon or the physician attending the patient. During the pre-op teaching, for a patient who is diabetic, you have to understand that the patient who is diabetic, after surgery, they're going to be in a whole lot of stress. Their body's going to be stressed out. So stress is a very important component because stress releases hormones. In particular, your mineralocorticoids and your glucocorticoids, stress hormones. You have to anticipate that in the pre-op teaching, you have to educate the patient that we're going to be assessing your glucose more close because of the issues of hypo or hyperglycemia. If the patient is stressed out after surgery, which is a fact because their body has just undergone some type of disruption in their anatomy, they've been cut open, and things of that nature, that increases stress hormones. So that may increase the need for insulin after surgery. That's the concepts that I want you guys to understand. You have to think about all these various things. When it comes to teaching, you have to also think about respiratory. Who's breathing for the patient while they're under general anesthesia? It's not the patient, it's the machine. And who does a better job, us or the machine? We do. And because of that, now the patient's at risk for atelectasis. And because of that, we have to make sure we educate the patient about coughing and deep breathing every 2 hours. Every hour. Utilization of the incentive spirometer. And here's a question, do you inhale or do you exhale? When in doubt, guys, just remember, your mouthpiece is supposed to expand the lungs. So when in doubt, inhale. Okay, guys? So those are some elements that you're looking for in your pre-op preparation for the patient. You also want to assess CMS, circulation, motion, sensation. This is your neurovascular status. This is important because if the patient's going to have, let's say, cardiac catheterization. If it's through the femoral access or brachial access, you have to assess the neurovascular status of the distant extremities before and after the procedure. So I hope this gives a little bit of an insight into what you're looking for the pre-op patient. Another component that we're really looking for in the peri-operative patient is going to be the second component, and it's going to be your post-op patient. The post-op patient is very important for you to understand what's happening. They just had surgery. They were under general anesthesia for the most part. They have no gag reflex. The patient has not eaten anything. The muscles have not been contracting. So you have to start drawing a picture. What's happening with this patient? Well, to start off, no gag reflex. So before any PO alimentation, you have to assess the gag reflex and make sure it's intact. Talking about no gag reflex or the gag reflex, you also have to think about the patient's respiratory status. You have to understand that the patient that's been in surgery has not been allowed to cough like we cough in between breaths or throughout the day because the machine's breathing for the patient. And now you have a collection of fluids and mucus at the base of the lung. So this is when we talk about coughing and deep breathing. Atelectasis or lung collapse is a serious potential complication. You have to assess bowel sounds. You have to understand that within 8 hours after surgery, the patient does not pass gas or have a bowel movement. That's something that we have to report because there's something potentially going on, like an ileus. If the patient has some type of abdominal surgical procedure, now you have paralytic ileus caused by abdominal surgery. We can potentially nick some of those nerves and you've stopped peristalsis. So these are very important things that you guys have to think about. The patient's post-op, the patient has had venous stasis. Since no muscles have been contracting, the patient's muscles have not been contracting, so the venous return is not as adequate. So the patient is at risk for what? DVT. Because of that, you assess for potential DVT, a positive Holman sign. You also want to think about early ambulation. Early ambulation is a very important concept because the faster we get the patient out and moving, the faster he or she is breathing on his or her own, the faster the muscles are contracting, and it's reducing the likelihood of somebody developing a DVT, which can potentiate an embolism, and then you develop a pulmonary embolism, and now you have a whole host of other issues. These are some of the concepts that I want you guys to think about when looking at these questions. This is what they're asking you about. Another thing before I conclude my little lecture right here. The patient has been under general anesthesia. They've been intubated. So the patient might complain of a sore throat. The patient might complain of a dry mouth. They give anticholinergics before the procedure, which dries the patient up. So these are things that you have to think ahead about, and you have to understand if the patient has a sore throat, we can give them medications, but we always start with the least invasive. So we can do something as simple as warm saline gargles, but before you do that, what do you assess? Gag reflex. So I hope this kind of helped out, guys. There's a lot more information that it could be covered in peri-operative. Of course, I have limited time right now, but this is how you should address any of these questions regarding the surgical procedures or the peri-operative patient. I hope it